Hello, good morning.
Good morning. Welcome to Breast Cancer Dialogues. I'm Gregory Dennis, and we're here today with Dr. David Weintritt, a breast surgeon and founder of the National Breast Center in Alexandria, Virginia. Thank you for joining us today, Dr. Weintritt.
You're so welcome.
We want to ask you today about a recent article in the Journal of the American Medical Association titled Overdiagnosis and Overtreatment in Cancer, an Opportunity for Improvement. We'd also like to talk a little bit about breast cancer and molecular subtyping. Can you summarize for us the background and reasons for this article by Dr. Laura Esserman in JAMA?
Sure, Greg. I think I can. First of all, I think it was very helpful to shed light on the need to recognize that not all breast cancers are the same. And therefore, the next step beyond that is that they shouldn't all be treated the same. There's been a conception that every breast cancer case is going to have an identical outcome, therefore maximum resources in surgery, radiation, chemotherapy would need to be applied, but that's not the truth. Some patients will have a much less aggressive course, and so we need to be more aware of how to determine what type of cancer is present and create a plan that's more appropriate for the patient and not treat them as a group as a whole.
That's quite an interesting development. Tell us a little more about the role of genomic testing, which is also referred to as molecular subtyping, and the role that plays in preventing overdiagnosis and overtreatment of breast cancer.
Well, Greg, the secret to everything always lies in the genetics. There are certainly some cancers that occur because of an increased risk that the patient carries from birth, but that's a genetic issue. But once a cancer happens, whether it's something that was driven by a high-risk situation or whether it was a spontaneous mutation, the type of cancer and the behavior of the cancer is going to be driven by its genes. So the key, if we're going to try to not only categorize cancers as high risk or low risk so that we don't over or undertreat them, but as we also look into options of trying to develop a greater variety of treatments so that we can be more specific in treating cancers, we need to be using that concept of genomic testing or molecular subtyping. Now, there are tests, fortunately, today that give us that capability. The one that provides the greatest depth of knowledge is a test called MammaPrint, which is one version of genomic testing. And by looking at the human genome and finding the genes that are consistently associated with breast cancer, as well as identifying one of the 4 different molecular subtypes of breast cancer, you're able to tell with each individual patient what their likely outcome is and how aggressive their treatment course should be, and in some cases, fortunately, how the course of treatment should not be aggressive at all.
Tell us more about what you mean by how in some cases the course of treatment should not be as aggressive.
Well, Greg, if you look at known outcomes from patients with certain gene signatures, and again, I'm talking about when you analyze a cancer, recognizing that all cancers are going to be different in certain ways, but that those differences are going to be very subtle and sometimes based upon the over or under expression of certain genes, you'll find not an insignificant but quite a large group of patients with breast cancer will have a very low risk that that cancer will ever spread. And I think this is one of the key things that the author is trying to shed light on, and that not all women with breast cancer should be worried about their cancer spreading or should be worried about potentially dying from breast cancer, and therefore should be going through treatments like chemotherapy. This low-risk group has a less than 5% chance over a 5-year period of time of their cancer ever spreading or showing up anywhere else. Therefore, we see in that group, there's no need for extensive chemotherapy regimens or treatments of that nature because their risk is already low whether they receive chemotherapy or not.
I see. Now, you mentioned MammaPrint, which I guess helps determine the risk of recurrence of the cancer. Tell us a little bit about the Blueprint test, and these again are part of the Symphony panel of tests. Where does Blueprint figure in?
It's been well recognized that there are 4 basic types of breast cancer, each of which functions very differently. There are the luminal group comprised of luminal A and luminal B. There is a group that overexpresses a receptor we refer to as HER2, and then there's a group we refer to as basal, otherwise known as triple negative. The molecular subtyping will categorize patients into one of those 4 groups. They'll be one of the 4. They won't be a mixture. And that's very important because responses to things like chemotherapy, need for chemotherapy, or in some cases, no need for chemotherapy will be delineated differently amongst those groups. And so paying attention to the molecular subtype will make the treatment plan much clearer for patients. And I think it actually helps patients understand why we make the decisions, which is very important in this process.
How is the introduction of the use of genomic testing and molecular subtyping different from what used to happen? This is new information, or relatively new types of information you're dealing with. How is it different from the way you used to understand and diagnose breast cancer?
So in the past, and I'll be honest, I still think in the present in some situations, although not in my practice, if you looked at a group of 100 women with breast cancer, you would know that roughly 40% of them would benefit from chemotherapy based upon the chance of some members of that group having one of the higher risk types. However, without specific tests such as MammaPrint, it would be very difficult to know which 40 women were the high risk out of that group. And so the default decision would be, in order to not undertreat anyone, to recommend treatments like chemotherapy to almost the entire group. And while I don't disagree with the concept of let's make sure that patients are not undertreated, now that we're able to more accurately identify the patients and we can now begin to pull the high-risk members out of that group with an accurate selection process, we can also, fortunately, not overtreat. Very important, as we have this array of options for treatment, that we make it fit the patient's needs. The concept of overtreatment and undertreatment is very important. No one wants to undergo chemotherapy, but if we identify accurately that it will be beneficial to their survival, then they see the reason to do it and they're very compliant. On the other hand, if we have a pattern of recommending chemotherapy to every patient with breast cancer, we're going to become a little disingenuous in applying those treatments, and unfortunately, many patients will receive it that don't need it. So that is the huge benefit of advancements like molecular subtyping and genomic analysis so that women can receive treatment plans that are much more accurate.
I think there's a natural tendency among women who have breast cancer to say, let's do everything, to be sure that we're safe, to be sure that we've taken care of the cancer. But I gather there are problems with overtreatment as well. How do you see that issue? What are some of the dangers of overtreatment, or why should we be concerned, as well as not to undertreat, why should we be concerned not to overtreat?
Well, Greg, you have to be very careful when we make departures from what previously were considered standard recommendations. And I always, one of the first things I'll do is put myself in that position, or try to imagine what it would be like to have a cancer diagnosis and determine what do I think is the best course for it. So I don't disagree, and I certainly can understand that previously, when women were not aware of or able to understand or have people explain to them what their outcome was going to be, that they would say, give me everything, give me whatever is available, because I don't want to face this recurring or have to ever deal with it again. But now that we have the ability to select those groups, we're able to explain to them not just our gut feeling, but scientifically how they're able to avoid overtreatment and avoid chemotherapy. And getting to the second part of your question, the reality is patients have a very small chance, but a real chance of potentially dying as a result of chemotherapy. There are secondary malignancies that can occur. There are situations where patients can become anemic or susceptible to infection during chemotherapy. There are quality of life issues that can occur with chemotherapy, neuropathy, infertility, many things that don't just happen in the moment but can linger on. So it is a very important balance of understanding the risks and the benefits and not applying something in a situation where it's not going to help.
Thank you. I think we've covered most of the key points. Is there anything else regarding the article in JAMA or the issues of overdiagnosis and overtreatment we should touch on today?
Yeah, I would like to make one last statement at least, in that the article comments on the need to begin placing patients into low-risk group and high-risk group. And I commend the author because that is, in some cases, a significant change in mindset. And when you look further also in the article, it mentions that our screening process has increased the number of favorable cancers, but has not led to a significant increase in the diagnosis or detection of unfavorable cancers. And they're viewing that as a potential failure of screening. But I think the appropriate way to look at it, Greg, is that since we've developed so many less invasive techniques for diagnosis and treatment of breast cancer, finding lower risk types earlier allows women to go from the beginning to the finish of their treatment process much faster, with fewer side effects, and a greater quality of life. So the screening process has benefited those patients. Now, it would be a complete dishonor to not deal with the other half of that, where you have a group of women that are still presenting with later stage breast cancers that are potentially lethal. So we use, again, this concept of molecular testing, genomic testing, tests like MammaPrint that decode the genetics of the cancer, to use it and to develop new therapies so that we can make an impact for that group as well. So screening is not a failure. There are ways that screening has been successful for allowing women with less invasive cancers to undergo shorter courses and less invasive therapies. But we also have to recognize that it's not perfect for some of these other types of cancers. Does not mean we should abandon screening, but we have to continue to aggressively pursue the genomic testing concept and utilize it to find new ways to treat women with more aggressive cancer types.
Great point. Thank you very much, Dr. Weintritt. It's been a pleasure talking to you here today on Breast Cancer Dialogues, and we appreciate you taking the time.
You're so welcome. I hope it has been helpful information, and we'll enjoy to continue to see the evolution of this concept and more appropriate therapies for women now and in the future. Thank you very much.